Mr. Chairman, dear Filippo, dear colleagues, it's a pleasure for me indeed also to be here in this beautiful country in China. So thank you for inviting me. I set some goals for this presentation. First of all, I want to make some publicity for our journal. Second, I want to invite you to a marketing strategy when submitting papers to our journal by an impactful title and a nice visual abstract, because that's exactly what I'm going to use to present during this presentation. And of course, as our chairman just indicated, we're going to speak about cardiogenic shock. Normally, a meta-analysis, and it's a little bit provocative, a meta-analysis is a good reason to turn the page for an editor of a journal. This is not always true, because we are looking also for individual patient-based meta-analysis, because these will show novelty and impact. A classical meta-analysis cannot overcome this with aggregated statistics. But still, there are exceptions. And what I'm showing here on this cartoon is one of these exceptions, looking into the patient profile of patients in intensive care trials. And what we learn over there is that patients with heart disease are fairly underrepresented, either be heart failure or either be ischemic heart disease. So really, if we are looking to trials in the intensive care world, we have to be careful about the patients that are there. But also in the field of acute cardiovascular care and even big trials in the field of cardiogenic shock, we learn that we have to be careful about the patient population in the trial. Happily, as shown here by the corporate shock trial investigators, we are always happy to have a registry next to the initial trial to show us really the relationship with the real world and the randomized clinical trial. And it's shown on this cartoon. What you see is that if we put next to the patients included in the corporate shock trial studying multi-vessel disease treatment options, interventional treatment options, what you see there is that indeed, if we look to mortality, that mortality in the real world in patients with multi-vessel disease is a little bit higher than the mortality of the patients that were included in the trial. And what is shown on this cartoon as well is if you put them, lump them together, and then look to the number of vessels that were attained, there you can see that there is an incremental rise in mortality. Two small lessons taken from this trial, but why is this? And why is it important to look also to the patient characteristics when you are appreciating a trial? And this is really shown by these investigators. Patients not included in the trial had more anterior ST segmental elevation myocardial infarction, received more fibrinolysis, and had higher median creatinine levels. Also, following the procedures, the result was less good. Less patients had a TB3 flow. And there was more use of impeller, but also intra-aortic balloon pumps. So giving a hint that these were more sicker patients. But at the end, within the power of this trial and this analysis, the 30 days mortality was only slightly 5% higher in the registry patients as compared with the initial trial, but still pointing to the fact that indeed looking carefully to the type of patients included in the trial is tremendously important. Also swimming with sharks, if you look to the shark classification of patients in cardiogenic shock, there you will see also, and this was a large registry done, registry analysis done by the group of Dr. Berg, where they studied nearly 9,000 patients with cardiogenic shock and divided the patients according to the shark classification to see which type of patients were included. were they hypovolemic, distributive, mixed, or were these patients fairly and basically only in cardiogenic shock. And there you see the split out of these patients in this patient cohort. Is this important? Well, that's what these investigators were showing us. Indeed, if you look to the mortality in patients with mixed shock, distributive next to cardiogenic shock, for instance, there you see that the mortality is already higher as compared with patients that were basically in cardiogenic shock alone without other characteristics. So you can already divide the patient population according to this type of classifications, but you can also look to certain biomarkers, like CRP. And this is exactly what was done in the ECLS shock trial in a subgroup analysis, where the patients were divided in tertiles and where the investigators were showing us that according to the tertiles of CRP, an indicator of inflammation, in this patient population, that according to these tertiles, that indeed mortality went up in this patient population in a straight line. Same thing for liver failure. If you take the MELT albumin score as an indicator of liver disease, there also in patients with cardiogenic shock, as shown by these investigators in a retrospective analysis in nearly 1,800 patients. Again, based on tertiles, you see that according to the tertiles of liver dysfunction, that mortality went up in patients with cardiogenic shock. And we can continue on this one. We can continue on this one when looking to renal failure. And we know already in renal failure in the postoperative care, but also renal failure in patients with ACS, but now also in patients with cardiogenic shock, that next to CRP and to the MELT albumin score as an indicator of liver dysfunction, also renal failure is a clear indication of short-term mortality, but also long-term mortality. Not only renal dysfunction pre-existing, but also new renal function was an indicator of mortality at the long end, as was shown by these investigators in a Danish retrospect cohort of nearly 1,500 patients. As indicated and as said, so around 45% of the patients developed renal failure, with 25% needing renal replacement therapy, and the mortality was 30% higher, clearly significant. When we now step away from the patient population, but towards the indication, so cardiogenic shock, purely cardiogenic shock, but then in a specific subgroup of patients, being patients in cardiogenic shock after aortic valve disease, there we see that over the last years, the indication or the prevalence of cardiogenic aortic valve disease in cardiogenic shock is increasing. And if we then look to the technology at our hands to treat these patients, there you see that TAVI is appearing as a strong new player in the field. And if we compare TAVI towards surgery in treating patients with cardiogenic shock due to the aortic valve disease, there we see that in-hospital mortality between TAVI and surgical treatment is fairly the same, but the number of patients developing stroke or number of patients developing acute kidney injury, as indicated, an indication of short-term and long mortality, the number of patients developing major bleeding were decreasing with TAVI. There were, and this is obvious also, the number of patients with peripheral vascular complications was increasing. This was put into context in our journal by Dr. Prendergast, who was also indicating to the same points, saying, look, in patients with aortic valve disease, severe aortic valve disease, and developing cardiogenic shock, clearly, TAVR seems to be the treatment of preference in this patient population, resulting in an in-hospital mortality that's around 10% and a 30 days mortality around 13%. And these numbers were taken from the STS-ACC TVT registry. So putting the paper into context and adding additional information. Now I should give the word to Dr. Aziger, who is also in the room, because it's always difficult to speak about trials when one of the lead authors or lead investigators is in the room. But I will try to do so, and if I make mistakes, Christian, please come up to the microphone and help me out. So two major trials done in the field of cardiogenic shock, the ECLS shock trial and the danger shock trial. I think both will be familiar to you, and both were published in the New England Journal of Medicine. But there were differences. One trial was positive, danger shock. One trial was negative, the ECLS shock trial. And one of the elements that came up, perhaps this difference is due to the fact of patient selection. And here we are again. Patient selection in trials is tremendously important. So let's go and look, because one of the elements in patient selection in the trial was the fact that in the ECLS shock trial, also patients following out of hospital cardiac arrest were included in the trial in a more routine way, not in a very selective way. So Uwe Zaimer from the ECLS shock team, trial team, came up with this analysis, and he went to see if there was a difference within the ECLS shock trial between the danger-like patients and the not danger-like patients. And this is stipulated over here in the trial, where the vast lines are the patients that went on ECMO versus control, and the stipped lines were the non-danger shock trials, patients into the trial. Again, VA ECMO versus non-VA ECMO. And basically what you can see and appreciate on this cartoon is that there was no difference in the trial in danger shock-like patients versus non-danger shock-like patients. So there was no signal whatsoever that the fact that patients after out-of-hospital cardiac arrest, including or not including in the trial, would have made any difference. An important element also when considering these trials, ACLS versus danger, is the fact of peripheral complications. And this is a study done in 501 patients in a retrospective registry, where they looked to VA ECMO patients at 30-day mortality, and they appreciated that the 30-day mortality was around 40%, so much in line with the major trials. Importantly, with VA ECMO, and that's something that is known for this technology, is the fact that 50% of these patients developed device-related complications. 40% were bleeding, 26% were ischemia, and 23% were neurological events. And indeed, all were linked to mortality, as shown in this cartoon, with clear odds ratios going up from 0.44 to 0.94. If we stay with the VA ECMO, another question that comes up, should we treat these patients with unloading, early unloading versus no or late unloading? That was a question that Dr. Lim put it up on, and again they went to investigate in a rather large patient in a patient population of around 115 patients. They went to see if early unload would make any difference. This was a prospective trial, not a retrospective analysis. This was a prospective trial, and in this prospective trial they came up with the evidence that it didn't make any difference between early unloading or late unloading towards mortality and outcome in this patient population. What made the difference, however, was not the fact of unloading, but what made the difference is the way that how you treated the patients during PCI in patients with acute myocardial infarction, in cardiogenic shock, and then looking peripheral approach versus a femoral approach. Would this make any difference? And this is again a sub-analysis from the ECLS shock trial, where the investigators indeed show that mortality in patients that were approached via radial access, this patient death-to-day mortality was lower and significantly lower than via the femoral access. So indicating that also in this critically ill patient population, treating these patients for their coronary artery disease, radial access is the way to go, like in standard care. Was it related to bleeding? Well, there was no difference in bleeding between the two patient populations, so it should be something else than just the bleeding. Please to recall you, in Matrix, we clearly showed an additional or associated bleeding reduction when going radial versus femoral. This was not seen in this patient population, regardless. So, pointing to the fact that also in this patient population, we should focus on operator expertise and procedure planning. A type of information that also comes from this analysis done in the Netherlands in 1,500 patients. This was a retrospective analysis, but coming up with the same type of information. So confirming the information in the ECLS subgroup population, indicating that transradial access indeed was better than transfemoral access. If we then look why patients were chosen for a transfemoral access, there might be a signal towards the message that is appearing. And this is the fact that the patients with transfemoral access indeed were fairly sicker than the patients treated by radial access. And I'm ending up with this pharmacological message, and this is something also done by the German investigators from the ECLS shock trial, but they were the same as the one from the culprit shock trial. And in the culprit shock trial, they looked after the fact if cangrelor, an intravenous ADP receptor inhibitor, fared better than other P2Y12 inhibitors, for instance. And there they saw indeed that in patients that were treated with cangrelor in cardiogenic shock due to an acute myocardial infarction, this resulted in a lower rate of stent thrombosis. It was along an acceptable bleeding risk, and next to the lower rate of stent thrombosis, there was also a lower rate of reinfarction. If we compare these numbers with, for instance, the culprit shock trial, there you see that the same trend was prevalent, but that indeed, as compared with the culprit shock trial that we take as the other series of classical standard of care patients, you see that patients treated in the CAN-SHOCK trial with cangrelor intravenously, the message was that less stent thrombosis, less bleeding, less cardiovascular death, less combined endpoint. So indicating that indeed cangrelor might be a way to go. And this was confirmed also in DAPT-SHOCK trial, where you see that if you're giving cangrelor intravenously, and this is now pure pharmacologically, that platelet inhibition was achieved faster and to a much higher extent early than with the cangrelor, potentially given an explanation. However, also, if you look to a pure ischemic endpoint, being death, MI, and stroke at short term, but also at longer term, being either intention to treat or per protocol, you see that there is a statistical difference between the two treatments in favor of cangalor. So, and if you then look to other components like cardiovascular death, all-cause death, and ischemic stroke, there you see that for all-cause death and cardiovascular death, ticagrelor fared better. There was a small numerically increase in stroke, but that didn't reach any statistical effect. There is a caveat, however, in the DAP shock trial, being that intravenous cangalor did not achieve superiority over the standard treatment when you consider the 30-day all-cause death, myocardial infarction, or stroke, and that this trial at no way was powered to detect differences in mortality. But regardless, there was a clear signal that there is something going on in favor of cangalor, and for that reason, much more research is necessary. So I want to thank you for being with us for this presentation, and I also want to point to the fact that we are going to do a digital and AI summit. So I'm just being the messenger, and the leader of the band is back in the room. So for you, just this message additionally. Thank you.